there is not a problem of timing, but it was a problem of performing.
What are the most common traps or pitfalls that they should pay attention to?
I have done for many years, like doing individualized healing abutments with a flow composite or just simple composite. I just did it too big.
Algirdas, what a joy to have you with us at Straumann ProTalk Clinical in this special edition of the International Aesthetic Days in Portugal. Thanks very much for joining us.
Thank you. Thank you for having me here. It's a big honor.
Now, with pleasure. I would like to start our conversation with some foundational elements. In your point of view, in your workflow and the framework of your workflow, how do you currently define a successful outcome in terms of emergence profile with immediate implants in the posterior region?
In immediate posterior region, so we try to be really with emergence profile around 30 degree. So we have papers from Catafucci, for example, or also Nikos Mateos and one of mine together with Nikos Mateos and co-authors about Pythagoras theorem for just calculating this mathematically, this angle. We know that 30 degrees like right to go. However, in clinical situations, so sometimes we have a different clinical situations and not all the time you can manage with 30 degree. So that's why by just analyzing and looking, okay, what like a red line could be for this emergence profile. So we give for us and allow us to be okay with 45 degrees. So it means that up to 45 degree, especially to lingual or buccal side. If it's mesial or distal, it may be even more, and it's not so dangerous usually. But buccal and lingual or palatal, it's dangerous. So that's why not exceed this 45 degree.
So when you say deangulation, 30 or 40, from which point to which point? Because, for example, the abutment can be 3.8 or 4.5. Now we're having this angle, but then there will be the superstructure that will be cemented to a tie base, a varial base in Straumann case. Then you will continue. From where to where do we have that calculation?
Yes, from the point where abutment goes outside of an implant. So it means that implant and abutment connection. From
That's
this
the base.
Point, that's a base. And where our tooth comes out of a gingiva.
Got it.
So this is the 2 points. And when you connect them, so it should be like not more than 45 degree.
Got
so
it.
This is like a definition for me. Better 30 degree, but okay, 45, it will be like a gray zone. Excuse me, a red zone.
Red zone. That's where we draw the line that you start becoming critical. Now, looking at how dentistry evolved, and we have very sophisticated software that we can pretty much plan, which was very different from the past. I'm quite sure that in the past, without these three-dimensional possibilities and maximizing, it was not so accurate to find that sweet spot of 30 or 45 degree. How early on today with planning softwares do you think it's really critical that you already anticipate how your emergence is going to look like in order to plan your implant?
From very beginning.
First step.
Normally, I have like intraoral scannings and CBCT, and I send it to my dental technician, and he is doing a project for me. We know already that from the reference point, from a buccal side of a gingiva, the implant should be placed at least 3 millimeters deeper.
I love it.
And only this, when it's like a visualization for me, then I can just adapt. Okay, let's move it a little bit lingually or palatal or buccally. Let's go it 1 millimeter deeper, etc. So then I can just design again and just correct a little bit. But like initial, it's from very beginning, because we have to define the correct implant position, 3D positioning from very beginning. Doesn't matter, it's the aesthetic zone or it's posterior zone. And sometimes in posterior zone it's even more important for longevity.
I love how you describe it because it feels like a GPS in a car. You don't punch in a whole bunch of streets and then it will end up somewhere. You punch in the destination.
Yes.
And from there you start coming
just
your
my
path
way
forward.
of the pathway.
In that case, you start with the restoration. And that's how you want that emergence profile to start from, and everything bottom comes after.
Comes after, and then we just say, okay, I would like to have this and this prosthetic part, and then here's my platform, and only then I just define, okay, what is the length of implant, what is the diameter of implant, how much bone do we have around, what a soft tissue condition, and yes, sometimes we just agree on some compromise.
Yeah.
Maybe to avoid a huge bone grafting, to avoid some very short, very small placement of implants. So just agree on something. But it will be like conscious planning, not like I do implants and when a prosthodontist and lab, we just have to break down all the thing and then just think how to figure it out.
Right. And in this context that you just described, which I like very much, and thinking that sometimes anatomically speaking, as you said, the contours are not necessarily at the right place. You may have some discrepancy. What are the most common traps or pitfalls that you think, or you could tell clinicians that they're starting this indication that they should pay attention to when approaching?
What I see really in social media is still very often done, and what I have done for many years, like doing individualized healing abutments with a flow composite or just simple composite, I just did it too big. I'm just trying to touch or even sometimes just push soft tissue already with my individual healing abutment. And I still see constantly, just see in a social media, it's like done like this. And we see that it heals like very nice with very, very individualized like socket. But later you want to also with your final crown to apply a gentle pressure. Right. And it already looks like with tooth with recession, so no need for that. So
you had a chance to build, but instead you pushed.
Yes.
And that's what you will.
So it's a constant mistake. I think what should be changed with the time.
I would like to pick your brain in the following. Let's play a role here. Let's assume I had a cavity evolved to an endo, a crown. Now my tooth crack half open. I walk to your office, you take an x-ray, there's a fracture, I'm diagnosed for extraction. What is Algirdas Puisys' workflow in my situation?
Yeah, so here we have like two ways. One way, it's like a regular, if everything is still can be in place, so we can scan, we can do CBCT, we can just plan our next visit and prepare a surgical guide and maybe just to pre-plan everything what I need for that. But sometimes it's really like a case is like an extra case. You have pain, you have also already inflammation. If I schedule your appointment after 1 week, you will lose already a few millimeters of bone there. So maybe I will do it immediately. Just I will extract the tooth, I will place an implant, I will place an anatomic healing abutment or maybe standard abutment. So it's also kind of good to think. And if implant will be in the middle of a socket. So because the single tooth, I have all reference points. So yes, if I trust myself that I will get a good primary stability and I position the implant also in the correct position, so I can go straight forward and to just leave office already with the implant and with abutment. And after 3 months, maybe 1 or 2 visits, and you will get a crown. So
at this point, you would normally approach with a conventional round healing abutment, or you would try to customize, like you mentioned, socket sealing?
So in our practice, it was like very interesting. So we started first of all with standard ones.
Right.
Then we switched to composite. Individualized with composite. But with individualized composite, they are really not hygienic, and very often we see a plaque accumulation. And honestly to say, I don't like this so much. Plus, it takes more time to manufacture it. So then later we switched to like delivering the final prosthetic abutment from zirconia, titanium base and zirconia, and just screwing it in, and then for next day or maximum after a week, and just letting the patient to heal it. But if something happens and the prosthodontists don't like this design, it becomes like very expensive healing abutment, right? So I came back really to the standard abutments, rounded one. Especially now we have like a 7.5 millimeters, so it's beautiful one for this. But my implant should be in the middle,
right?
So if it's not in the middle, so when I just place a standard one, but also I scan it before, and I just ask my lab to mill the individualized one.
I see. In PMMA?
Yes, in a PMMA.
Yeah.
And now I keen to introduce also to my practice the chair-side 3D printing machine.
Right.
What Straumann offers, and to do it everything right in after surgery, just with half an hour, 1 hour after the patient just waits for it, and then he leaves already with temporary crown or with individualized healing abutment. So this will be really like additional step for convenience, and also less visits and less invasiveness.
I like it very much. And I like to pick also your brain in the context of you've been one of the early users of the anatomic healing abutment, which particularly I see with very good eyes, right? From day one to optimize the emergence, as you mentioned, with the right angle, and then eventually you don't disturb the soft tissue anymore. It sits there. And once it's healed, it's already with a scannable head. So you don't have to all this push and pull, all this transition and additional purchases, and then disturbance of soft tissue. So you just scan it, and the next time you will only disturb that tissue is already to switch to a final crown. How was your experience? Is this something you can rely on and recommend?
Yes, absolutely. So I was involved in development of anatomic healing abutments in the first project, because it was like a two-stage of it. And honestly to say, I liked our design more than it was changed later. So, and I hope the third generation will be also a little bit adapted to ideas what we brought that time with a group, with several key opinion leaders were, but with this idea of anatomic healing abutment, to combine healing abutment like semi-individualized together with scan body, it's awesome. Indeed, like a normal workflow, and what should be, and slowly everybody will go to this. So every time a patient comes to the office, we will scan it and we do CBCT. As you said before, and as you mentioned, your what happens for workflow if something breaks in your mouth. If you are mind patient, so it means that I have your CBCT and I have your scanned tooth and everything what is in place. So even if it will be 1 or 2 years old, so I still will be able to plan a surgical guide for the implant placement and for anatomic healing abutment. Because if it's changed something a little bit, 1 millimeter on one another side, so it doesn't matter so much. So it means that if you tell me that you have a problem, you describe it, but the moment you come, I will have already a surgical guide and anatomic healing abutment, what will be pre-planned. So when all surgery, it takes just what it takes to remove traumatically to extract the tooth. When implant placement will be just 5 minutes together with everything what is includes implant placement and maybe socket preservation, etc., and placement, anatomic healing abutment. That's it.
You know, as you were talking, I was just reflecting how many touch points, which you explained today, that is heavily based on digital dentistry, digital technologies. It's irreversible, isn't it?
No. But it's a funny thing to see how resistant our brain is. When we master some routine, right, just to break it in this inertia, and to just develop a new skill for a new routine, it takes time. But it's unstoppable now. So with digital innovation and all this, it comes and it will be changed. So it's no way back.
You know, I was talking to Herman Gallucci a few months back.
Okay.
And he was contextualizing. He says, I can't wait to read systematic reviews that will come 20 years from now to see how dentistry will reflect the success rates based on the help of digital technologies. Isn't it amazing how?
Absolutely. So, yeah.
Algirdas, let's shift gears a little bit. I would like to know from you, we have this session called It's Not What We Think. Not work. Well, your hands, many things can work well, but it's not what we think that we say, oh, it works in my hands. It's what we know based on evidence, correct? I would like to know from you if there is a moment, an article, or a case that when you came across, there was a turning point in your career that you said, aha, this was like an aha moment for you that you say, yes. That's it, and you think our audience should become aware.
The tipping moment, yeah. Yeah, so I can remember I was really very conservative with immediacy in the first decade, maybe 15 years of my career. As evidence-based showed that we have like recessions, it's dangerous, it's not good, it should be like very strict case selection. And ITI Consensus 2009 was showing this, and 2014. It was 2014, this paper, I just read it, I would say maybe 7 times. I just analyzed it. And I took all these papers what were included. The conclusion of the paper was that it's still dangerous. It's still, you have to really be careful, better to avoid immediacy, etc. But I just realized that all these publications, what was included, they were really very different, with different approach. With lap, flapless, with temporary, without temporary, with soft tissue graft and without soft tissue graft, with bone, with no bone, different initial situations, different measurement. It was like heterogeneity was tremendous. And 3 papers, and one particular by Joseph Kahn, was like showing there's no difference between immediacy and early delayed approach or delayed approach. So, and when it was a click for me, yes, there is not a problem of timing, but it was a problem of performing, just to do everything in the right way. So it was like a click in my head that we cannot compare the different timings. When one timing, like early or delayed, we are doing like correct, like we just make a nice flap, we just place implant in correct 3D positioning, we just augment bone, we just do maybe some soft tissue management with another timing, with immediacy, for example, with immediate implant placement. When we place implant in the wrong position, when we don't do soft tissue grafting, so
then immediacy is dangerous.
Yes, but this is not about an immediacy. It's about just how do you do this. And this was like a click for me. No, immediate implant placement. So this is the thing what we have to go for, because it's less visits, it's less invasiveness. It's like a smaller surgery. It's a gentle surgery. It's easier to learn, like other timing techniques, and the patient comfort is much higher. So I see just advantages. So no single disadvantage. Of course, we have some contraindication for immediacy, for sure. It's just, there are cases when we cannot do it, but normally, so it's not like about the timing, which is bad timing or dangerous timing. No, this is just, so this was like a tipping point for me.
There are guidelines as long as we check the boxes.
Yes.
That's a default route.
Absolutely.
I like this. I would like to pick your brain on something. This is very personal. You have a very heavy backpack of experience, right? You're known for excellent work in the context we're talking about, not only in the posterior region, but also in the aesthetic zone. All this experience that you have put in that backpack, now you're excellent, but you have not always been excellent. Let's put it that way.
Absolutely.
Is there something that you know now that you wish you knew back then, if you can reflect the clinical situation that you said, I wish I had that patient today because he would have done quite different, huh?
Yeah. You know, I have to disagree with you. I am not excellent. I'm far away from excellence, and I think as a doctor, you cannot say for yourself that you reach already a certain level of excellence, and now you can relax and stop, learn, stop, improve. So this is never-ending story, I would say, and this doesn't mean that it's bad, yeah, but it's this disappointing something, right? But this is, yeah, and I don't think that I reached my even close with really perfect excellence, and I have many regions, many areas where I have to improve myself, starting both the clinical work, like professional work, as well as personal things, like from daily life. But coming back to your question about what I wish to know that time, and in this area about immediacy, molar area, for example. So somehow I wanted to place the bigger implant as wide as possible in the beginning. And very often I just occupied all space, or just removed some remaining bone, and instead of getting a good primer stability, like a lot of bone around my implant or a lot of soft tissue around my implant, I did an opposite. Either implant is in a bone and healed, but almost no bone around the buccal and palatal-lingual side, or no soft tissue thickness, and then some recession later, or even was not able to place an implant because no primer stability. And I have like my implant in a hand, and
right.
I had to say for my patient, "Oh, sorry, but I just was not able to place an implant. We just come back in 3 months." Sorry for
that awkward conversation.
Yeah.
We
So it's just like you're feeling like you did something bad. Like,
right.
So it's
we
just
go home.
Like
it was not a good day.
That's why now what I changed and what we are doing now. So in molar area, the biggest implant what I take is 4.5. But very often I just go for 4 millimeter or even 3.75, because now, indication and thickness of a wall, 3.75 is already really very good implant.
Less metal, more biology.
Absolutely.
And that was this particular situation that you remember?
Yes. Yes.
It made you, that was the learning point.
Yes. It was like a friend of mine, and she had some issue with a molar, so she came to my office. I said, "Oh, no problem, so I will do it." And extracted the tooth and just tried to place an implant one time, another one, take it out, and again, and it was like inconvenient, and they say, "Sorry, I give up."
But we have to agree to disagree, because you just disagreed with me, but I will have to disagree back, because you are an example to us, your curiosity. I'm not saying that you become the highest that you can possibly be, but we are mindful, because I've been to your practice. I saw you operating when we launched the TLX. I was there. You were the first ones, and I saw how much care you take. You prime for excellence. It doesn't mean, as according to you, your standards, you're not excellent, but you prime for it. So there's not one single step that I have witnessed that you neglect. In my opinion, this is excellent. So congratulations to you.
Thank you, Jerry, for this.
I would like to pick one more time. There's this one block that I say, well, despite the fact that in the end we're health professionals, we provide care. Yet there's this particular indication that we develop a bit of an affection to it, that every time, that day will come across with this indication, you say, I'm so happy I'm going to get to do this. Not because you're happy that somebody's losing a tooth, but you're happy that you're going to come across that something that you spend some time developing because you like that approach. And in the end, that patient will go home with something special. What will be your favorite approach?
The two things comes to my head, like an ideas. So one thing is that more and more we see and we understand that in the end of the day, soft tissue plays a major role for biological health and aesthetics, of course.
Right.
Because more and more evidence coming that having bone around the implant, but in the same situation having a poor soft tissue, we lose not aesthetics only, but also we lose bone. And opposite, even having no bone around the implant neck, but having a healthy soft tissue, fixed soft tissue, we may maintain such kind of implant for a very, very long time. So please understand me correctly. So I don't say that we don't need bone, right? The bone and the soft tissue, like a complex together, this is our goal to just create such condition. However, in many, many cases, we have this gray zone, just to place an implant and to augment the bone or not. And every time when we go for bone augmentation, we increase our complication rate 5 to 10 times, right? Does not matter how good I am, I will have definitely higher complication rate immediately I just start to augment the bone. So that's why in many, many cases now, even having 2-3 millimeter of exposure of an implant on a buccal site, we still go for soft tissue augmentation at first. And this is not very highly clinically evident, right? We have not such strong clinical evidence now, but I'm sure it will come in the next years, which will show that soft tissue augmentation is enough in majority of cases. So that's why I'm so excited, because I just can reduce my complication rate, and most important, the patient satisfaction rate will be also much better.
I love this. And do you see this also for longer span?
Yes.
Like 3 unit?
Absolutely. This is what I'm just talking about, also for longer span. And the second, of course, always peri-implantitis treatment story. Many cases, we just are able to treat conservatively and to get bone grow back, just bone remineralization. And this is like a wow effect for myself until today, when you just have like initially bone loss, suppuration, bleeding, like all peri-implantitis signs, and after several hygienic phases and some time, the bone remineralization happens and you don't need to do anything anymore. So this is really, like I said, from a medical point of view, from a medicine point of view, it's like a real treatment, right?
Yes.
Real treatment.
These are some of the examples that we get so passionate and excited about that only dentists will understand.
Yes, absolutely.
Algirdas, it's been a real pleasure to have you with us. And I understand that, and I've been to your clinic, you're involved with a lot of educational activities. If our audience would like to learn more from you, where they can find you?
Algirdaspuisys.com. So it's my
that's simple.
Page. Yes, that's simple.
One more time?
Algirdaspuisys.com.
We're going to leave the link.
Oh, thank you very much. Yeah, so welcome.
It was a real pleasure. Thanks once again for having and spending this time with me in ProTalk. Straumann ProTalk Clinical during this special edition International Aesthetic Days in Portugal. Thank you very much.
Thank you very much. Thank you very much.
And to all of you, if this content was relevant to you, make sure you give it a like, you subscribe to ProTalk channel on YouTube and all the major streaming channels. And until the next episode, stay clinical, stay tuned.